Alright, so this week we're going to be going over the lower extremity. This is 112 slides on this PowerPoint, so we're not going to cover all of them. We're just going to go over a few highlights, a few things we missed during probably the first semester, but we should give you a nice overview and a few more hints to kind of go through. Positions we'll be going over: toes, feet, calcaneus, ankle, lower leg, meaning the tibia and fibula, the knee, and a little bit of the specialty views of those. Tunnel views and tangential views, and then a couple views of the femur. Alright, so starting with the toes, generally you'll have to figure out which centering point your clinic's like. Some clinics like to have the entire metatarsal on there, others are just fine with the three parts of the three phalanges basically of the foot. When we're looking at toes, basically you want to isolate the specific toe that you want to see. You can get a little bit of the toe next to it, but you really shouldn't have the far toe on the lateral or the medial part of it. Toes should also be marked as either 2, 3, or 4. 1 is an obvious toe that you do not need to mark because it only has 2 phalanges. And the 5th toe, there's no toe next to it, so it should be pretty easy for the radiologist to identify the 5th toe. But the 2nd, 3rd, and 4th toes generally look the same. It can be easily mixed up, so make sure that you do mark them with a little lead marker that says 2, 3, or 4, as well as your right or left marker on theirs too. What you want to see on this is you want to see the soft tissue of the toes as well. The soft tissue will help you to figure out if there is any sort of rotation on there, so make sure that you look at the soft tissue on both the lateral and the medial side. Look at this one right here. You can see that there is a little bit more tissue over here. You can see the nail bit is going the opposite direction as well. So as you know, that is not a perfectly straight AP image. Let's see, analysis here. Flex, you want to make sure that the toes are straight out so that you can see the DIP and the PIP on here. So you should be able to see this one. You'll see, well, just the IP joint on this one, but you should be able to see these joints open nice and well as well. If it is more of a distal injury, sometimes you have to put a little bit of an angle on it to get the distal phalanx on there. Oblique projections, you'll see different techs oblique them different ways. Generally you're going to oblique them similar to the foot like this, but occasionally it'll help to get an external rotation sometimes to get the toe on there so that you can see it. So talk to your techs and see what they like to do. You can tell this patient right here, their toes are going a little bit down at the distal ends. Their toes are kind of curling under, so like I said, if it's more of a distal injury or you suspect a DIP injury, then you can put a little bit of an angle on it to open those spaces up. This one not quite rotated 45, it's kind of rotated but not all the way. If you really look at the soft tissue there, you can see generally this is going to slide over. The sesamoid bone will be in between the two instead of still on the head of the first metatarsal. Laterals are really up to the technologist's skill. Some techs are really good at it, some techs are not good at it, but what you want to do is you want to be your patient advocate and kind of manipulate the foot as much as you can to try to open up those spaces, because maybe there's one little tiny fracture that will only show up on the lateral. So this is really up to how much the tech really wants to get a good lateral image. And you can send more than one lateral image. If you bring the toe back and that works pretty well or it doesn't work very well, you can put the toes the opposite direction and pull this toe down. So you have to kind of use a little bit of critical thinking on there and say, well, have I shown, as much detail as I need to see on this? Tape definitely can help. I'll tape the individual toes a lot of times because the big toe, you can really move that pretty well. The 2nd, 3rd, 4th toes, usually you can put one piece of tape on those, but every once in a while I'll put a piece of tape on each one of these just to open it up a little bit more. A little bit of overlap there, so not out all by itself. Another lateral toe, doesn't look very lateral. You can probably see the little chip fracture right here at the distal phalanx, kind of in between the proximal phalanx as well. Make sure the metatarsal heads are lined up on top of each other. You can always send all the images you have, so make sure you're not limited to just one view that you want to send for one particular lateral. AP foot should just be straight on. Should be able to get the skin line on there as well in case there is some soft tissue swelling. You should mark what side or what area of interest is on the foot. It just helps the radiologist not have to go through all these bones in the phalanges and metatarsals and tarsal bones. It helps them to have a little marker on there somewhere. Generally, a little lead arrow will help them. Let's see. TMT joint spaces are closed. C are not aligned parallel with these joint spaces. So tarsal, metatarsal joint spaces. So these right in here. Can't see any of them. So looks like the angle not quite there. Should be 10 to 15 degrees on that for most patients, depending on their arches. Medial oblique foot, so make sure you don't oblique them too much. Just should be a true 45-degree rotation on this. Generally, you want to kick the heel out a little bit when you do this. So if they're doing it on the table, when you rotate the foot or the knee towards the medial aspect, what you want to do is kick this heel out just a little bit, just to get a nice straight line going all the way down here, so that we don't have a problem getting the talus on at the very, I would say, proximal portion of the foot. This one here, lateral cuneiforms, cuboid, navicular, intertarsal are closed. Okay, so this is starting to look kind of like a lateral, so it's kind of rotated a little bit too much. So as you see here, it's over rotated, so make sure you decrease the amount of rotation. So that means the knee would have to come up a little bit, bring in really the lateral portion of it down closer to the IR. Laterals, just make sure that the metatarsals are on top of each other, so these should be lined up on top of each other. If you can see the base of the foot, that's nice to be able to see that on there, but you shouldn't see it so that these are all separated on here. So I'm sure there's an example of it right here where all the metatarsals are separating a little bit. Make sure that your marker is down in this area. There's always room above the metatarsals to get your marker on there. And this is the right amount of tib fib to have on there. A little bit of dorsiflexion of the foot going straight up and down. Just go from the longest toe all the way to the heel to the skin line. Should be fine. This one's a bit rotated, like we just said. A lot of metatarsals separated, not quite on top of each other. The base of the fifth comes out really nice, so if they have base of the fifth problem, probably want to include this as well. We're going to look at this as well, so if you look at how far the fibula is coming down, it shouldn't come down that far. So make sure you kind of go over each one of these slides. Calcaneus, just make sure that the foot does not turn inward a little bit. If it turns inward, generally the fourth and fifth metatarsals are going to come out a little bit more, which is what we kind of see here. So I would say that this is, I would say externally rotate the leg. I wouldn't say internally rotate. That might be an error on there, depending on which way they're orientating this. But the fourth and fifth metatarsals need to be tucked back behind here a little bit. So you should turn the foot towards the outside portion over towards your marker on this one. Lateral, no real problems on that. Just make sure that you get the entire calcaneus on there. You can get a little bit of the tib fib on there, but not as much as you would on a regular foot series. Ankle, AP projection. So occasionally you'll get something like this where your mortise will be open on your AP. We kind of talked about that during the first semester on that. So keep this image just in case you need it as your extra mortise view. Obviously there's a fracture right here through the medial malleolus. So make sure that you get a good AP view. If you did this and this was your AP, you would externally rotate the foot just a little bit to close off that space a little bit, because this looks more like a mortise than anything else. And we do need a solid AP view. 15 to 20 degree rotation. You can over rotate it a little too much. So if you over rotate it too much, you might get this space here. This space is going to disappear though. So we should be able to see all three parts of this joint space on there. So on this one, you would externally rotate the foot just a little bit. Calcaneus obscuring just last week. Foot was in plantar flexion, so make sure it is dorsiflexed a little bit instead of extended. This looks like it was, well, they're talking about plantar flexion, which is correct. But dorsiflex the foot until it's at axis is 90 degrees from the lower leg. So just basically a 90-degree right angle, and that will help open that space up a little bit and keep the talus from getting underneath the lateral malleolus in this case. Lateral should be straight on. Just notice where the tib fib are aligned. It should be, I would say, in the back half to third of the tibia when you're looking at it from a lateral view. Maybe I have a couple examples of that. Correction there. This one too far extended down. So if you look at it right here, it's too far down. Tib fib, straightforward. Just get from the ankle going up as much as you can. Notice where the kneecap is though. The kneecap is over the femur. So if you have light, like the entire kneecap covered with light, you are probably going to clip one of the malleoli towards the bottom on that. So make sure you always go from the malleolus up, and usually you'll get the proximal part of the tibia without any problem. Rotation should look very similar to a lateral knee because you are doing a lateral tib fib. So if you see that amount of rotation, you need to fix that a little bit. So it looks a little bit more like this, where the condyles on the back are right on top of each other. Your condyles inferior to superior are going to be off a little bit just because your centering point is right here instead of over the knee like it usually is. Knee, just watch the bend in the knee. Make sure it's not rotated at all. Patella should be right in the middle of your image. Intercondylar eminence shouldn't be shifted off to one side. You can see the intercondylar fossa also coming in at a little bit of an angle. So make sure it is straight up and down. Medial rotation of the knee. Lateral rotation of the knee. It's going to be the opposite, about 45 degrees each way. Let's see. CR angle to caudally. This should be straight on if you're doing a medial oblique. That should be at 0 degrees with the CR. So make sure you do not include an angle on it. Sometimes if you go back to an AP straight knee, you can angle 3 to 5 degrees just to kind of open that up. We kind of ran past that a few slides ago, but be aware that you can put a slight cephalic angle on the AP knee as well. Lateral knees. I think most of you are pretty much getting a good handle on this. I think you're recognizing that you want to aim for this right here. Those two condyles right on top of each other. So about that 5 to 7 degree angle is what you need to get that on there. This one, angle, not quite there, so you need to angle up a little bit more. This is the bigger condyle, which is the medial condyle. You can see the adductor tubercle off of that. So this right here would just require an angle going up a little bit. It looks like the angle was probably just forgotten on this view. This one, knee needs to be bent a little bit. Adductor, heavy part of it. Looks like it's right there. That looks thick too, so it's a little harder to see. It's hard because they get the angle wrong and they get it a little bit rotated on there. So make sure you check that and get the proper bend in the knee as well. This one, under rotated. You can see the adductor tubercle right here. So this is the medial condyle. So we need to lift the heel up. We need to bring the fibula back. We need to fix that rotation so that it's right on top of each other. Intercondylar fossa, the Holmblad method. I would just extend the foot out a little bit. Generally, I don't like it out like this. To just bring this straight out, so no dorsiflexion in that foot. We'll kind of relax the patient a little bit more. This one, rotation. Okay, you can't see the nice clear notch view that you see on this one. You can see the patella is shifted off to the side as well. Probably something you should save until you do your next Holmblad method on that. Another way to do it, the Beclaire method. It's just another way to do your tunnel view. We didn't really go over that this much, but you know, with an angle and the cassette like this, it creates a bit more distortion on that, but you'll see some techs use that occasionally. Tangential, so the sunrise views or merchant, skyline views are all pretty much the same on here. You want to be able to see the intercondyloid sulcus on here without any superimposition of either the tibia or the femurs going across on there, and you should be able to see both joint spaces going across on there fairly evenly. Now you have something like this, where you've got a little bit of invasion of the space here. So this particular book talks about either moving